I don't know if it is the case in your language, but in English and in French, when we are speaking about the phenotype, the very fine phenotype of a patient, we often speak about clinical picture. And you know that with picture, we are in Florence, here there are a lot of museums, and you know that with picture you have also classifications. Just give a look at that. You have six pictures. And we are going to do an experiment. I guess that there are some subgroups of picture among these 6 pictures. And I will give a clue to you. There are 2 groups of pictures. Well, it happens that, you know, 3 pictures with a red border are supposed to be closed, while the 3 others are supposed to be closed also. And you know why, because some are called Impressionist and the others are called Cubist, but this is another story. This is exactly what clinicians do when they find classification. From the ancient Greece, already they had melancholia, mania. They were somewhat different from what we call depression or mania, but they had also classification, and they had no neuroscience, no statistics. They only saw patients, a lot of patients, and they did classification. And so, for picture, you have art movements that can determine some sort of classification within picture. Oh, this is not so obvious, you know. Whether it is an art movement which defines the classification, or is it if there exists a common core among picture which make that the art movement exists, you know. This is a question of nominalism and realism, and this is an old philosophical question. Does words exist first or reality exist first? And this is exactly the same in psychiatric classification. Well, I am sure that among these 3 pictures, you have noticed that 2 are closer to one another. Of course, because these 2 come from the same painter, Monet. And this is exactly the same with the psychiatric classification. You have depression and you have also unipolar depression. We have a hierarchy of disease within classification. Okay, so this is a way to define a classification of picture, but you can also try to distinguish pictures that represent something and pictures that do not represent something. For instance, this is non-figurative painting. We could call that psychosis. You have figurative painting. We could call this neurosis. And you have also some pictures that are neither figurative nor non-figurative, and you can call them borderline. And this is perhaps what do also psychoanalysts when they do classification. You can also be interested in the material that has been used to do the painting. You know, you have aquarels, you have charcoals, and you have oil painting. And this is another way to do classification. And in a way, this is what does biological psychiatry. Well, so what is the classification of paintings? You know, you have art movements, you have the content of the painting, you have the painter, you have the period among ages, you have the material, you have interaction between all these, and you have many ways to classify paintings. And this is exactly the same with psychiatry. You have psychopathological theory, symptoms, societies, age, biology. There is an interaction between all that, and you have many classifications. For instance, well, this seems somewhat very complex, and we have to come back to the very definition. If we speak about classification of psychiatric disease, we have to come back to the definition of a psychiatric disease. And you know here that there is a question of language. For instance, in English, you have 3 words: disease, illness, and sickness. In French, we have 1 word for the three of them. And it is said that the disease is considered by the physician. The illness is expressed by the patient, and the sickness is the social point of view about the patient with the disease. As I told you, there is an old question about do these diseases really exist, or are they only construction? And this is an open question, and this is a philosophical question, perhaps more than a scientific question. And there has been a very good paper published in the Journal of the World Psychiatric Association by the philosopher, which said that in fact disease can correspond to biological dysfunction, syndromes, categories used by health insurance, and you know that if bipolar disorder is more and more into fashion, it is because it is a real disease that is reimbursed, and when you have a borderline personality disorder, you will not be reimbursed by your insurance in many countries. And so with time, more and more people are speaking about bipolar disorder, while 10, 20 or 30 years ago it would have been different. Categories used by judge, by the media, you know that the concept of schizophrenia is very different when it is a psychiatrist who use the word, or a journalist, and also sociologist. Okay, so how does it work? We have seen ICD-11, and clearly ICD-11 is based on symptoms, not only, but mainly on symptoms and syndromes. You have also some classifications that are adapted to some age. For instance, the recent DC-05 is a classification for the newborn or the very young kids. You have also some classification which come from some kind of psychopathological theory, in particular the psychoanalyst theory. And you have the PDM, Psychodynamic Diagnosis Manual, and you have the CFT-MEA, which is the French classification, which is mainly based on psychodynamic point of view. The CFT-MEA is for kids, and this 1 year ago they have also provided the CFT-MA, which is for adults. You have recently a classification based on biological constructs. You know, this is the RDoC from the NIMH, very interesting, very stimulating. Curiously, we have no classification coming from the societal point of view. And you have the classification of functioning from WHO, but this is not exactly the same thing. This is a real question. I think many times we psychiatrists are not interested enough on the sociological point of view. Well, this is my conclusion. On my point of view, no classification can pretend to say the truth. Of course, we have seen that some classifications are more reliable, more valid, and the word validity is a really complex word in psychometrics. Of course, the fact that the classification is effective, that is, it has a predictive value, is something valuable, but we have to be very cautious. For instance, if you consider a predictive value of a classification, the predictive value comes from studies, but studies, you have to obtain some money from grants to do the study. And many times, to have a grant, you have to do a design with very serious inclusion criteria that will rely on a serious classification. And so you will use this classification, and so you will prove that the classification has a predictive value, and this makes things like some crazy tautology, you know. If you have no money to study the predictive value of some outliers classification, then you will be obliged to say that there is no predictive value, and so very likely the classification is not interesting. As for paintings, the fact that we have many classifications is something very interesting, because this is a way to challenge our way to see patients, and we need to be challenged in the way we see patients. Why? Because we have too few times to see patient. And we want to be very quick, very fast. And so it is very tempting to see the patient, we see the family also, and to say, this is this diagnosis, and you have evidence-based medicine, and so the treatment is that. And so, okay, I take the money and see the next patient. And you know that, I'm sure, we are obliged in most countries to do that. We are obliged to do that. And I'm sure that many times you feel this is a shame. And so to think in terms of several classification, it obliges you to take time a little bit and to try to grasp your patient with more complexity. I will just give you an example. A couple of months ago, I have seen a patient with some externalized disorder. He had all the items of what we call conduct disorder. Okay, and he has conduct disorder, no problem. But most of his symptoms focused on his mother. This is not present in conduct disorder. If you think only on conduct disorder, there is a risk that you don't see the big part of the picture, which is that there is a problem between the kid and the mother. And of course, the treatment will have to take that into consideration. And this is only one example, and there are many, many other examples. When you oblige yourself to think in different terms, different classifications, suddenly you see patients different. And at last, of course, we have to remember that a patient is not a person with a disease, a person reduced to a disease. And this is also, there is some kind of transcultural issue about this. I'm not sure that in all culture we have the same definition of what is a patient. This is a proposal that we are working on in the IACAPAP. This is a subject or a community because we are working with communities in child and adolescent psychiatry. Most often our patients are a family. So a subject or a community that calls for help for some suffering in the mind or behavior. So our job is to deal with subject or communities, of course. And of course, we have to think, and one good way to think when you are a physician is to do categories, because it helps you to think, to communicate, and to use data coming from science. And thank you for your attention.